Today we are here with Maryruth Butler, President of Cascadia Healthcare North. Maryruth, how did you get started in this profession? Were there any people or events that made you choose this career?
You know, there were. I don't think anybody ever grew up thinking that they were going to be in long-term care. But I began working at Mountain Valley in Kellogg as the business office manager, and I had a wonderful mentor. And I was a few years into my bachelor's degree, and she suggested that I become an AIT. So my last year of my bachelor's degree, I became an AIT under her, and we just continued to grow. I received my license, got my degree, and a couple months later she announced she was leaving, and I was moved into the executive director role in 2001.
You have achieved numerous quality awards from AHCA, NCAL, and the Malcolm Baldrige National Quality Award, as well as helping lead your centers to 5-star quality awards from CMS. What keeps you motivated to continue your work advancing quality care?
That's exciting, and we're all very, very proud of that. I feel like this is kind of funny to say, but it's easier now being in my role than what it was being the executive director. Having been through all those experiences and all the learning makes it easier to stay calm during a pandemic. Not that we were all ever calm, but having the knowledge, the value based on experience, and being able to speak with young leaders about this is what happened, this was the outcome, this too shall pass, you're going to survive this, and just being able to bring the calmness, the experience, and create value for them keeps me motivated.
Absolutely, the calm in the storm. In what ways do you see quality care changing right now?
I feel like that if the pandemic hasn't taught us anything, it has taught us that we can do a lot virtually. We have run our organizations for the last 2 years on Teams and Zooms, and we've been very effective. We're doing lots of virtual medical treatments, lots of telehealth. In fact, we have communities, facilities that are very rural that because of COVID, they now have access to care because of virtual medicine. We're seeing psychiatrists, we're seeing lots more behavioral health that we can bring to our centers through virtual practices, lots of therapy in our rural areas where we can do those therapy evals. So I feel like virtual telemedicine is like something that it's taught us. It's also taught us that when we get that call at 5 o'clock at night and you have COVID in your building, that we have some pretty amazing leaders that haven't been practicing to that level. And so they have learned that they have a lot of leadership skills that they never knew they had, and they came out of it a lot stronger. And those leaders certainly have the foundation to motivate, to cultivate a team, hopefully attract lots of other new young leaders to our industry based on now their experience that can keep people calm, during turbulent times.
Definite opportunities there. Now, the industry overall is experiencing a workforce crisis. How do we continue to provide quality care and ensure that our patients, residents, and family, that quality care is still a priority despite these challenges we're navigating?
Yeah, that's a good question. So, all of our buildings are having nursing shortages. So I feel like that's one thing, and we could focus on that, or we could just learn how to do things different. And so part of that is, that telemedicine piece where we're bringing more services in via telemedicine. The other piece of it is support staff. We can train our support staff to do a lot of things that maybe a nurse doesn't need to do, but we've always had on that nurse's plate to do. Looking more at making education easier for nursing assistants, CNAs, LPNs that want to go to a higher education level, more online programming, speaking to our regulators, our legislators about how do we make it easy for rural America to have a CNA class where we keep it all online. We can do all of our clinicals on site. How do we make it easy for an RN to get higher education? How do we make it easier for an LPN to become an RN? So those types of things, looking at curriculums. We have lots of colleges, for example, a medication administrating assistant can free up a nurse for a lot of things. And lots of our centers don't use that because our community colleges don't have curriculum for that. So bringing those things back and learning that there is no norm, that, we can have an administrator helping in showers and administrators helping, serve in the dining room. So maybe we don't need all those credentials behind names. Maybe we need to look at a little bit different ways to provide that same level of care so we get the same quality. The other piece of that is, we have the clinical quality, but we also have the customer service quality. And so we really do need to go back to, we've had 2 years where families haven't been with their loved ones, our loved ones in our facilities haven't been with their families, and maybe we've forgotten a little bit about that customer service piece because we've been in that survival mode. So going back to new staff that haven't ever dealt with a family at bedside that has care concerns, how to deal with that, how to be able to articulate, what we're doing, and going back to that customer service piece, that is also a huge part of quality of care.
Absolutely. What advice or recommendations do you have for centers that are looking to improve their quality care processes?
So I think the first thing is to get back to our processes, right? In COVID, we were so defensive. I mean, I refer to it often as the firefighter that sees a blazing building. They put on all of their fire protection gear and they run to the fire when people are running out. We did the same thing during COVID, right? People didn't want to be in those buildings, and we were putting our PPE on and we were running into the buildings and we were leaning into it. So learning how to do that better is one thing in terms of improving quality and processes, but through all of that, we have kind of let our processes go just because we didn't have time. For example, the example I'll use is our quality assurance performance improvement process, right? We did it. It was in most cases an act of compliance. We checked all the boxes, for the regulators when they came in, but we lost our process where it was, very systematic and very effective, and where we were tracking and trending our data, and we were making really good decisions, and we were identifying root cause analysis. And so going back to the processes that got us where we were, pre-pandemic, that are going to help us emerge during the endemic and emerge successfully with our, our quality brands in place, our 5-star ratings in place, because we have those clinical outcomes, but getting back, to the basics of going back to our processes that worked for us before that. And, they're going to have to go through cycles of refinement, because right now, the processes that develop our work systems have changed. We're doing things way different now than what we did pre-COVID, and some of those things won't go away, some will, but how do we incorporate them in our old processes to come up with new processes to make sure that they're effective when we have really good work systems?
Absolutely, really making those best practices of today.
Yes.
Absolutely.
Yes.
Well,
Yes.
Thank you for spending this time with us and
You're
talking to us
welcome.
about quality care.
Thank you very much.